last time. So today I'm going to cover this. This is a brief part of the talk we had last time. And all of you must now know that the pancreas has got numerous biochemical secretions that come out of it, mainly the ones that enable us to assimilate food from outside. Okay? Food that we ingest must be accessible to us through pancreatic function. And the main pancreatic function, exocrine pancreatic function, is digestion of materials that we ingest and allowing these materials to be sterile enough. In other words, acidification of the material is done. And once the digestion is done, the food is made neutral enough for us to get it into circulation. Okay? Outside these activities, the pancreas is exposed to numerous diseases. And these diseases include inherited diseases and acquired diseases, and ones that we have, which we can inevitably get, like pancreatic malignancies. Okay, so I'm going to talk about the diseases of the pancreas, and I've enumerated them as cystic fibrosis, pancreatitis, pancreatic carcinoma, Zollinger-Ellison syndrome, and malabsorption syndrome. These are not really diseases, but their syndromes that are associated with diseases of the pancreas. So now we go for cystic fibrosis. The first one, it is also known as fibrocystic disease. Let me just remove this here. It's also known as fibrocystic disease of the pancreas, or some people call it mucoviscidiosis. It is an autosomal recessive disease, which is relatively common, and it occurs within a population as 1 in 1,600 live births, and it affects a single or multiple exocrine glands. Okay, cystic fibrosis transmembrane regulator is a protein which is defective in this disease. This defect results, defective transmembrane regulator results in abnormal chloride transport across membranes of these exocrine glands. It is characterized by dysfunction of mucus and exocrine glands throughout the body, including the pancreas. The pancreas is one of the exocrine glands. And here in this disease, we have very viscous mucus excreted by the glands, and this is stored within the gland. So it obstructs the ducts of the gland. So the excretory function of the gland. It presents as an intestinal obstruction in the newborn, excessive pulmonary infections in children, and pancreatic malabsorption in adults. So cystic fibrosis presents variably within these age groups. The small and large ducts of the pancreas or pancreatic acini dilate, and they convert into small cysts or bullae, okay? And these dilated ducts are filled with mucus. Fibrous scarring and destruction of pancreatic function can prevent pancreatic secretions from reaching the duodenum. So cystic fibrosis is characterized, in the pancreas, is characterized with obstruction of the ducts. And so pancreatic secretions do not reach where they're supposed to reach. As the disease progresses, there is increased destruction and fibrous scarring of the pancreas. The mucus can clog pancreatic ducts and bronchioles. There's bronchioles of the lungs. Okay, are we still together?
Yes, Dr. Wandolo, we're together.
Okay, so in addition to chloride content of sweat, in addition to this obstruction, chloride content of sweat is also increased. The rise in sweat chloride occurs due to abnormality of the protein cystic fibrosis transmembrane regulator. So the effect in that transmembrane regulator now makes obstruction of the sweat glands, and what comes out of the sweat glands mainly is concentrated chloride. Instead of it being processed in such a way that we only get a small amount of chloride in sweat, we get a concentration that more chloride is poured out. The fluid part is retained. So sodium and chloride concentration in sweat is the main determinant of this cystic fibrosis. Significant elevation of the concentration of both ions occur in 99%. This is the diagnostic test that we have for cystic fibrosis for anywhere, any of the glands, okay? 2 to 5-fold increase of sweat sodium and chloride is present in children. So in children, we have an increase of 2 to 5-fold, okay? Now this is how we acquire the sweat specimens. A pilocarpine nitrate is administered by ionophores, and then we collect sweat on cotton gauze, and we then analyze this. So we give pilocarpine. Pilocarpine is like an anesthetic, and it dilates the sweat ionophores, and the sweat ionophores now excrete most of the fluid you need for analysis. So this is how you collect it. We finish with cystic fibrosis. The diagnosis is done by sweat chloride in, chloride in sweat, sweat that has been obtained. The pancreatitis is the second disease. The pancreatitis is the inflammation of the pancreas. And when we inflame the pancreas, what happens mainly, autodigestion of the pancreas can result as reflux of bile or duodenal contents. It will occur into the pancreas. So as we autodigest the pancreas, now the pancreatic duct, instead of directing its materials to the pancreas, now directs materials from the duodenum to the pancreas. And here, the duodenal contents contain also bacteria. So it's a retrograde kind of infection to the pancreas. So pathological changes that occur in this disease include edema with large amounts of fluid accumulating. Is there something happening wrong?
No,
there is also cellular infiltration. There is necrosis of the acinar cells, and sometimes there's hemorrhage. And this hemorrhage is intrahepatic or extrahepatic. And there's fat necrosis within the pancreas. So pancreas, when inflamed, becomes edematous with large amounts of fluid accumulating, with cellular infiltration of materials, and cells die within this pancreas. So it is a very excessive disease or extensive disease in the acute process. A majority of times we have, the pancreatic disease, pancreatitis, can be classified as acute, where there is no permanent damage to the pancreas, or chronic, where usually we have irreversible damage to the pancreas. And we can also have relapsing or recurrent, which is an acute and chronic pancreatitis. Typically, acute pancreatitis occurs in two forms. We have the acute one, in which there is no pancreatic damage, and the relapsing or recurrent one, which a majority of times presents as if it is chronic acute pancreatitis. So we may have one or two types of pancreatitis in any individual, okay? This disease occurs in middle life. Midlife is like in 20 to 40 there, or 20 to 50. Pain can occur intermittently and frequently is accompanied by nausea and vomiting. So acute pancreatitis as an intermittent pain with nausea and vomiting. A majority of times, these people must give you a history of ingestion of alcohol. So pancreatitis is often associated with alcohol abuse, okay? Or sometimes biliary tract disease, or rarely with hypocalcemia, in which it is often associated with hypoparathyroidism. We are likely to get pancreatitis. So patients with hyperlipoproteinemia and those with hyperparathyroidism are also significantly increased risk. Okay, so pancreatitis is associated with alcohol, associated with hypocalcemia, associated with hyperlipoproteinemia, or also associated with hyperparathyroidism. So these are the disease associates of pancreatitis. The other etiological factors for acute pancreatitis are infections, and the infections include viral infections, and then we have obstruction of the biliary tree, gallstones, pancreatic tumors, tissue injury, atherosclerotic disease, and maybe shock. So these are all associated with pancreatitis. Pregnancy, hypercalcemia, hereditary pancreatitis, immunologic factors associated with post-translation can also be seen acute pancreatitis. Pregnancy and hypercalcemia, it's not hypercalcemia, it's hypocalcemia. So correct that one. We have decreased calcium in circulation, which could caused by hypoparathyroidism. Now, how does acute pancreatitis present? Acute pancreatitis has no specific presentation. Any severe acute abdomen, we must rule out pancreatitis. So the etiology of chronic pancreatitis is similar to that of acute pancreatitis, but chronic excessive alcohol consumption appears to be the most common predisposing factor to chronic pancreatitis. Okay? So the pancreatitis does not have any specific or cardinal clinical presentation. It presents with severe abdominal pain, just like all the other abdominal viscera. So anytime you have an acute abdominal pain, pancreatitis must be considered. In the laboratory, we have this measurement. Increased amylase, lipase, and triglycerides are cardinal features of acute pancreatitis. Hypocalcemia may be found because of sudden removal of large amounts of calcium from the extracellular fluid, okay? And this is because when we have inflammation, we have edema. So the fluid in the cells leak out into the periphery, and this dilutes the calcium. So because of impaired mobilization, or as a result of calcium fixation by fatty acids liberated by lipase action on triglycerides, okay? So when lipases act on triglycerides, calcium is fixed or calcium is utilized, and this reduces the peripheral calcium. So in the laboratory, what we look for is the amylase levels, lipase levels, and the cholesterol levels, okay? We can also look for calcium levels. Or we can also look for protein levels, because hypoproteinemia, which is due mainly to loss of blood fluid into the edema space, okay? So peritoneal space usually has loss of protein into it, and this reduces protein in the circulation. There's also a shift of arterial blood flow from the inflamed pancreatic cells to less affected or the normal cells, and this causes oxygen deprivation and tissue hypoxia in the areas of damage, including the surrounding areas. So pancreatitis can start as a focal infection of focal inflammation, but gradually the surrounding tissues are also involved. So Acute pancreatitis can be localized, but it can also be generalized. Yeah, are we still together?
Yes, Dr. Wandolo, we are together.
Okay, so the enzymes that we use for diagnosis of pancreatitis are amylase. So amylase is one that is typically done for acute pancreatitis. Amylase increases within a few hours and reaches a peak of about 24 hours and remains above, returns back to normal within 3 to 5 days. Okay, and this is usually due to renal clearance. We can also measure urinary amylase, which is a more sensitive indicator of acute pancreatitis. Okay, so we measure serum amylase and we can measure urinary amylase. So the increase in the concentration can correlate with the severity of the disease. So urinary amylase, the increase can be used to assess the severity of the pancreas or pancreatitis. Lipase increases in serum in acute pancreatitis. So the two enzymes are the typical ones. In fact, lipase is the most sensitive one and the one which occurs early, okay? So both amylase and lipase may be significantly increased in serum in many other conditions, like in opiate administration, in pancreatic carcinoma, or in intestinal infection, obstruction or perforation, and pancreatic trauma. Okay, so these other things increase. And acute pancreatitis, any amylase and lipase increase, but these other conditions may also increase the lipase and amylase levels. Now, the main diagnostic enzymes for pancreatitis are amylase and lipase. Pancreatic carcinoma. Pancreatic carcinoma is the fifth most frequent form of fetal cancers. It's one cancer that once you have it, you have got no way out. More than 90% of patients die within 1 year of diagnosis. Most of the pancreatic tumors of these pancreatic tumors are adenocarcinomas, and the adenocarcinomas of the duct epithelium. Okay, because the pancreas has rich supply of nerves, pain is the most prominent feature of this disease. Note that most malignancies do not present with pain, but pancreatic malignancy is one which uniquely presents with pain. So persistent or excessive abdominal pain is one must rule out pancreatic malignancy. If the tumor arises from the tail, detection does not often occur until an advanced stage of the disease. This is because the tail is located its location is not associated mainly with the vagus nerve. The vagus nerve is the main supply of the pancreas. And here it is one which notes the pain for you. So most of the body and head of the pancreas have rich vagal nerve supply. And anytime you have malignancy in those positions, pain is a very typical presentation. Cancer of the head of the pancreas is usually detected very early because of its proximity to the bile duct. Any time we have malignancy at the head of the pancreas, we tend to obstruct the bile duct. And when we obstruct the bile duct, we now cause retrograde accumulation of materials that are usually drained by the bile duct. So pancreatic tumor of the head of pancreas is commonly associated with accumulation of materials like bilirubin. So jaundice is a common presentation of this tumor of the head of pancreas. So the signs of this tumor are those. I told you that the typical symptom is severe pain. And here, the signs of this tumor include jaundice, weight loss, anorexia, and nausea. anorexia and nausea are generalized symptoms for any GIT disease. Jaundice is the main sign with signs of post-hepatic hyperbilirubinemia. This is intrahepatic, which is a differential for intrahepatic cholestasis. And there is also low fecal bilirubin excretion. And this results in clay-colored stools. Okay, so there is an obstruction, or we have clay-colored stools or pale stools. Tumors of the islet cells of the pancreas affect the endocrine areas, okay? And if the tumor occurs in the beta cells, we have hyperinsulinism, and is often seen resulting in low blood glucose and often followed by hypoglycemic shock. So tumor of the islet cells will give you endocrine presentations. Pancreatic G cell tumors overproduce gastrin and are called gastrinomas. They cause Zollinger-Ellison syndrome. So Zollinger-Ellison syndrome is not really a disease of the pancreas, but it is a consequence of gastrinomas. These tumors are associated with watery diarrhea, recurring peptic ulceration, and significant gastric hypersecretion or hyperacidity. So a majority of patients who have gastrinomas may have features of peptic ulceration. Are we still together?
Yes, Dr. Wandolo, we are together.
All right, good. So pancreatic alpha cell tumors produce glucagon, and glucagon causes increased glucose in circulation. And these are rare tumors that can be associated with diabetes mellitus. Okay. Now we finished with the pancreatic carcinoma. So we go to the syndromes and of tumor of the G cells of the pancreas, gastrinomas. Okay, it's a rare disorder associated with tumors that arise in the pancreas and duodenum and ulcers in the stomach and the duodenum. The tumors secrete gastrin, which is a hormone that causes the stomach to produce too much acid. Okay, and this in turn produces stomach and duodenal ulcers. So Zollinger-Ellison syndrome is a disease in which pancreatic tumors produce gastrin, and gastrin leads to excessive production of hydrochloric acid. The ulcers caused by Zollinger-Ellison syndrome are less responsive to treatment than the ordinary ulcers. So a majority of time, people who present with peptic ulcers may be given traditional or classical do not respond to this. It's diagnosed by using blood tests that measure levels of gastrin and gastric acid. Okay, so gastrin and gastric acid, and this usually is done through an endoscope. So endoscopy is done, and we aspirate the stomach contents, and as we aspirate, we can be able to assess the presence of gastrin and gastric acid. Gastric acid is hydrochloric acid. So the primary treatment for Zollinger-Ellison syndrome is proton pump inhibitors. And the proton pump inhibitors reduce production of acid from the oxyntic cells in the stomach, okay? And they promote healing, okay? Then the promotion of healing, they promote healing, and they are the first line of treatment. Surgery to treat peptic ulcer or remove tumors of the pancreas or duodenum are other options, but rarely do people touch the pancreas. They're in fear that Anytime you touch the pancreas, you may release pancreatic enzymes and digest the whole abdomen. So anytime that people touch the pancreas, they fear. The last syndrome in this group is malabsorption syndrome. The malabsorption syndrome is also a consequence of pancreatic diseases. It is associated with all pancreatic diseases, and all pancreatic diseases lead to diminished pancreatic exocrine function, which leads to compromise in digestion and absorption of nutrients, and this leads we have pancreatic insufficiency or inability of the pancreas to secrete the exocrine secretions, we have malabsorption. So malabsorption is associated with abdominal bloating and discomfort, and the frequent passage of bulky malodorous feces and weight loss. Malodorous means foul smelling, okay? Bulky, foul smelling stools, loss of weight, and frequent passage of bulky, foul smelling stools and loss of weight in a patient who has a bloated abdomen, we think of malabsorption. And when we think of malabsorption, we frequently think of reduced pancreatic secretions. Now, this syndrome is associated with failure to digest or absorb fats, and these stools are greasy and they have greasy appearance. Okay? These are floating feces that have greasy appearance. So malabsorption syndrome typically involves abnormal digestion or absorption of proteins, polysaccharides, carbohydrates, and other components as well as lipids. So lipid malabsorption is the most typical one, in which we have steatorrhea. And steatorrhea is measured with stool fat. We also have disturbances in electrolytes, water, and vitamins. And this is particularly for those fat-soluble vitamins, as they cannot be absorbed. In addition to pancreatic exocrine deficiency, the malabsorption syndrome can also be caused by biliary obstruction. Okay? When it is biliary obstruction, it is mainly a fat malabsorption. It's because the bile ducts or the biliary components, the bile components contain bile acids, which increase uptake of lipids. Bile acids increase breakdown of lipids, and we can absorb the lipids. So the malabsorption syndrome, in which we typically may be a biliary obstruction. So biliary obstruction deprives the small intestines of the emulsifying effect of bile acids. So various diseases of small intestines also can inhibit absorption of digested products, and this may lead also to malabsorption. So malabsorption typically is a pancreatic disease, a biliary disease. Now, how do we assess gastric function? So gastrointestinal function, usually when we have malabsorption, we test it with what is called D-xylose. D-xylose absorption test. D-xylose is a pentose sugar that does not require pancreatic enzymes for its absorption. So when we have D-xylose and we have a malabsorption, okay? So patient with suspected malabsorption syndrome, normal D-xylose points towards pancreatic insufficiency. Okay, so D-xylose is absorbed irrespective of pancreatic function. Okay, so you can also do radiological tests, and X-ray and ultrasound can be done in gastric function. Okay. Pancreatic function or pancreatic insufficiency. Depending on the etiology and clinical picture, pancreatic dysfunction may be suspected when there is increased amylase or lipase. Tests that are used for detection of malabsorption, examination of stool, examination of stool, excess fat, desireless test, and fecal fat analysis. So pancreatic function is mainly done by assessing amylase and lipase. Here, the tests for measuring other exocrine functions include secretin, cholecystokinin, fetal fat, and trypsin and chymotrypsin. Tests associated, assessing changes associated with extrahepatic obstruction are bilirubin. For malabsorption, we must test for bilirubin. So endocrine-related tests that reflect changes in the endocrine cells of the pancreas include gastrin, insulin, and glucose. Direct evaluation of the pancreatic fluid include a measure of the total volume of pancreatic fluid. Hello? Hello?
Yes, Dr. Wandolo.
Are we still together?
Yes, yes.
Okay. A measure of total volume can be done. Okay. So the amount and concentration of, there's something that has happened here. What is it? The amount or concentration of bicarbonate and enzymes require pancreatic stimulation. And pancreatic stimulation is done by secretin and cholecystokinin. So the stimulation may be accomplished using a meal, and this is called the Lundh test, and or administration of secretin. Secretin stimulation is followed by cholecystokinin stimulation, and this adds enzymes to pancreatic fluid. Okay, so anytime we do a pancreatic function, when we want to do direct pancreatic function, we inject patients with secretin, and secretin will stimulate production of cholecystokinin, and cholecystokinin will stimulate. So the advantage of this test is that the chemical and cytological examinations are performed on the actual pancreatic secretions. Okay, so once we inject these people with secretin, then we stimulate cholecystokinin, the secretions are collected from the stomach. So we get in an esogastric tube and sac pancreatic material, okay, this often establishes the presence or at least suspicion of malignant neoplasm. So here, as we aspirate the gastric and duodenal contents, we are also able to aspirate cells. So we can be able to see cells as well as the pancreatic contents. Because of advances in techniques or in imaging techniques, so most of the tests have found clinical utility in excluding pancreas from the diagnosis. So most of the tests that we do exclude the pancreas from malabsorption diagnosis. So the sweat test is used for screening for cystic fibrosis when used along with the clinical picture at the time of testing, and they can be important in diagnostic information. So when we do a sweat test, we want to identify certain pancreatic disorders. Lundh test is a direct pancreatic stimulation function test in which the duodenal contents are collected for 2 hours following a meal containing carbohydrate, protein, and fat. So we feed people a certain amount of carbohydrate, protein, and fat, and then we allow them to digest. Okay, within 2 hours, we should have had quantifiable digestion. So low enzymatic activities like amylase, trypsin, or lipase indicates pancreatic insufficiency. So when we collect this amount of in the stomach, and we assess them and we find the low activity of this means pancreatic insufficiency. It is less informative than the secretin cholecystokinin test because it does not differentiate between pancreatic response due to reduced ability to secrete or reduced ability to transfer contents. Okay, so when there is pancreatic duct obstruction insufficiency, we are not able to identify this using this Lundh test. Lundh test only assesses a pancreas in which the duct is patent, okay? And that the stimulation is also intact. We can also do fecal fat analysis, okay? And in fecal fat analysis, we have fecal lipids, which are derived from 4 sources. The fecal lipids are the unabsorbed ingested lipids. We can also have lipids excreted into the lumen, and this is predominantly in the bile. And then we have cells that shed into the intestine, and we also have malabsorption or metabolism of bacteria. So these are the sources of fecal, free that still fit 1 to 4 grams of lipids within 24 hours. With the lipid-rich 24 hours. Are you with me? Hello?
Yes, Dr. Wandolo, we can.
Yeah, I'm being shown here that my internet is unstable. Is that right?
Yeah, it's all right. It's all right.
Well, can you hear me, Lakini?
Yes, we can hear you very well now.
Okay, so increased fecal fat can be caused by biliary obstruction or disease of small intestine. So we can also have fat malabsorption due to this. So severe steatorrhea is usually due to exocrine pancreatic insufficiency or a disease of the small intestines. Severe steatorrhea is one in which the 3-day fecal fat is much, much greater than 7 grams per 7 grams, 21 grams for those 3 days. We also have quantitative screening, fecal screening, and here fat can be assessed using dyes, okay? Dissolve in fat, and we can be able to quantitate the fat in stool, okay? And Sudan, so these are details that I don't need to go into. This is not whatever I want to tell you. So those are the diseases of the pancreas, and I've covered the 3 diseases and the 2 syndromes. The 2 syndromes are Zollinger-Ellison and the malabsorption syndrome. Both Zollinger-Ellison and malabsorption syndrome are consequences of either pancreatic or intestinal diseases, okay? So I have finished with the pancreas. So I'll go into this other one, and I will ask you if you can allow me to have 5 minutes, 10 minutes break. 10 minutes break, then we can come in.
Okay. There's one question in the chat box, if you can answer it.
Let me see the questions in the chat.
Just one.
Chat. Okay. Hello, Doc. How does xylose help in xylose does not require digestion? Okay. So when we have these xylose ingested, it will all be taken into circulation. Okay. So if it is pancreatic insufficiency, okay, if there is pancreatic insufficiency, it will still be taken into circulation. Okay. So these xylose does not appear in stool in both pancreatic insufficiency in both pancreatic insufficiency and the GI tract disease. When there is a local problem in the GI tract, then this xylose is not absorbed. Okay. So this xylose, when ingested, you get it in stool. So lack of absorption is now telling you the problem is not in the pancreas, but it is in the GI tract. That's how it does where it says pancreatic insufficiency. Did you get that one? Hello? Hello, who asked this question? I can't see the name of the person here.
Marty. The question.
Yeah, why can't she talk? You see, I talk to you. Why don't you people talk?
I think I've muted everyone. Okay, they can unmute and speak now.
Okay. Hi, Doc. Can you explain association between hypercalcemia to pancreatitis? Pancreatitis, not hyper. I removed that hypercalcemia. If you are there, I corrected that hypercalcemia.
Hypocalcemia.
It is hypocalcemia, so I don't want to explain this.
Yes.
I explained how hypocalcemia occurs. It occurs because of the edema, the fluid, one, and the other one is that when triglycerides are broken down by lipases, we use calcium as a cofactor, and that uses up the calcium. Now this is Mujerule, Mujerji.
Yes.
You got that?
Hi, yes, Doc. Thank you so much.
Yeah, it is not hypercalcemia. It's hypocalcemia in pancreatitis.
Okay.
Yeah. Now, I don't have any other, do I?
I had another question. The tail of the pancreas. Why is the detection of that delayed?
The tail of the pancreas is not as heavily supplied by the vagal nerve or vagus nerve as the body and the head. It is farther away and it is partially innervated. So poor innervation is what causes lack of sensation or pain sensation. Are you answered?
Yes, thank you, Doc.
The tail has less innervation compared to the rest of the body, the body and the head, where we have heavy innervation, and anytime we have nerves in an area which is inflamed, pain becomes a very prominent thing. Okay. So anybody else?
Yes, there's another question. Cindy had asked, how is imaging used to diagnose pancreatic malabsorption?
I would not be able to give you an answer to that one. I'm not on the imaging side.
Yes, we can ask doctors on radiation, radiology.
Yes, so as when you get to the radiation, then you ask those things. There's X-rays. When you get to that side, can you ask how imaging is used to diagnose pancreatitis?
Okay, Doc. So we can begin after 10 minutes.
Yeah, 10 minutes. So right now, my clock is saying we begin at 12.
No problem, doctor.
Okay, so 12 o'clock.
Yes.
So,
Recording stopped.